Okay, this lecture is going to be inherited color vision anomalies. We're going to look at the congenitally inherited color vision anomalies. Okay, so what are the characteristics? So we're going to look at one by one, yeah? So people with anomalous color vision process chromatic information differently than individuals with normal color vision. So that is a basic concept. Okay, so we the one who are normal, we interpret colors or we discriminate colors differently from those who are actually having color vision anomalies or color vision deficiencies. So there are a few characteristics that they are going to be slightly different than us. Okay, one of it is the spectral sensitivity. So we're going to look at all the characteristics. Yeah, spectral sensitivity, wavelength discrimination is going to be different, and the color confusion lines and perception of saturation. So we looked at the normal characteristic through the properties of colors in earlier videos. So now we're going to look at how these people are different from us. Okay. So the spectral sensitivity, we start with the chromatic system. So in normal trichromacy, the color opponent spectral sensitivity function manifests at 3 peaks. That means we have 3 types of cones, and the cones are maximally sensitive. Okay, at 440 nanometer for blue cones, 520 nanometer for green cones, and 620 nanometer for red cones. So this is what normals will be seen. But patients who are actually having deuteranopia or protanopia, as I mentioned earlier, they only have 2 types of cones. Okay, so the other type of cone is not existing in them. So they won't have the third cone peaks as how for the normal one. So we're going to look at the graph on how the sensitivity, the maximum sensitivity peaks that a normal, the one with color deficiency would have. So if you look at this picture, right? So trichromacy means we have all the 3 cones. So we are the normal one. So you will have 3 peaks. Okay, for red, for blue, red, green, and red. So we have 3. But when it comes to patients who are protanopia and deuteranopia, where they only have 2 types of cone, obviously they're going to have only 2 peaks. Okay, protanopia, they won't have the red cones. Okay, so they only have this and this. Okay, while for deuteranopia, they don't have the middle one. They only have the small one and also the longer one. But the middle one would be missing because they don't have that cone. Next will be spectral sensitivity, the luminance function. Okay, so trichromacy has a broad peak in the region of 555 nanometer. Okay, result from the addition of the medium and long wavelength cone input. Okay, so if you see this yellow color, okay, so this yellow color is the spectral sensitivity, the luminance function for a normal person. So this is how it looks like, and it reaches the peak when all 3 combines together, all 3 cones are working together, or whatever cone that is existing in the visual system is working together, the peak should reach at the 555 nanometer. Okay, but for patients who are having protanopia, the red one, since they don't have the red cones, so they will be actually, because it's absent, causes the luminance curve to be displaced towards the shorter wavelength. So it's going to be slightly shorter than the 555 nanometer. Okay, and this patient would be having difficulties in certain red objects. Okay, while for deuteranopia, okay, so they actually have missing of the medium wavelength, okay, cones. Okay, so they will be slightly shifted to the longer wavelength one, okay, area. So this displacement is actually minimal. Okay, it is not like red cones where they actually shifted, very far away. This one is slightly, towards the trichromat, but slightly longer wavelength. And then the next characteristic that this patient would have would be the wavelength discrimination. Okay, so as I explained in the the videos before, okay, this is how the normal people's discrimination. okay, where it is very sensitive for them to actually discriminate the colors from about 500 to 600 nanometer. Okay, while for the longer one and the shorter one is slightly less sensitive. That means if let's say I gave two colors with 10 nanometers different, okay, like for example, 552 and 560, the two colors, I know we, the normal people, able to appreciate that as two different colors. While if I give something like about 700 and 710, you might see the two colors about the same. You won't say they are two different colors. So the same applies for the blue color. Okay, when it is shorter, about 400 and also 390, okay, they won't be able to say that, you know, when we are given that colors, we won't be able to say that these two colors are different colors. So the sensitivity is lesser. Okay, now we're going to look at for patients who are protanopia and deuteranopia first. Okay, so based on this graph, okay, for protanopia and deuteranopia, there is relatively well-developed wavelength distribution in the length of 490. You can see the peak is over here, yeah? So, and the shortest that they have. Okay, but at longer wavelength, okay, beyond approximately about 545, about here, okay, there is no ability to discriminate color. So whatever that color that falls in this range, they will see all the colors to be the same. Okay, they won't be able to differentiate that based on the wavelength. They might be able to differentiate that based on the brightness and also the saturation of the colors, which gives a different contrast. But in terms of the color, they won't be. If let's say the intensity of the color and also the brightness and saturation of the color is already fixed, they won't be able to differentiate that. Okay. In tritranopia, this is tritranopia. Okay, there is well-developed wavelength discrimination at longer wavelength. Okay, but poor wavelength discrimination is about 495. That means they don't have discrimination. If you give any colors in that range, it all looks the same for them. Okay, so the color discrimination is going to be different for patients when they have this color vision deficiency. Okay. Now we move on to, this graph. Okay, so deuteranopia and protanopia have only why, they have this discrimination difference. Okay, deuteranopia and protanopia have only one photo pigment that absorb, beyond 545 nanometer. Thus, manifest monochromatic color matching in this region of the spectrum. Okay, so that whatever that is actually beyond that 545, then it's going to be difficult for them because they only have one photopigment in that range. Okay, so whatever that comes after that, it is going to be difficult for them. Okay, so the same applies for the blue-yellow defect also. So it's already explained just now. Okay, now color confusion lines. Okay, what are the colors that they get confused? Okay, deuteranopia and protanopia, the red-green defect. Okay, the colors that they get confused is the green, yellow, orange, and red. Okay, they get confused when these colors are put next to each other. Even if, let's say, a patient is having color vision problem, if let's say they look at the slide here, they might not able to see that these letters are colored differently. They might think that all the color, they look the same only for them. Okay. While for patients who are having tritranopia, they will get confused between blue, violet, and yellow. Okay. So those who are having tritranopia also will be having difficulties with this. Okay. Okay, now we're going to look at the inheritance of anomalous color vision. Okay, the prevalence and inheritance of the most color vision anomalies. Okay, the most prevalent one in basically male would have, the prevalence is higher in males compared to female, as I mentioned in the previous recording. Okay, and the most prevalent color vision problem is the deuteranomaly. The yellow defect where they have all three cones, but the yellow one is actually not optimally working. So that is the most prevalent one. And the least prevalent one is obviously the acquired one, tritranopia and tritanopia, because it's only prevalent about 0.005%. Okay, and as I say, it is autosomal dominant, so it is not a sex-linked gene. So it is not carried from one generation to another generation, and it only occurs when patients have some ocular conditions or when they are actually taking some drugs which is affecting the functions of the cones. So the rest is about the same. Deuteranopia, protanopia, and protanomaly is about 1% only the prevalence. Okay, so they are all X-linked. Okay, now we look at the transmission. Okay, so the transmission of red-green anomalies from parents to their offspring. Okay, how these are being transferred. Okay, so the red-green color blindness is a condition where a person has difficulties distinguish between red and green colors, as I mentioned earlier. So this condition is usually inherited, meaning it can be passed from the parents to their children through the genes, okay, through the sex genes. So our genes, which determine many of our traits, are found on structures called chromosome. So this chromosome is the one determine what are the characteristics that you carry from your parents to yourself and also from yourself to your offspring or your kids. So basically humans have 23 pairs of chromosomes and one pair determines our sex. Okay, so females have 2 X chromosomes while males have 1 X and 1 Y chromosome. So out of these 23 chromosomes that is in our cells, only 1 chromosome is the one that determines our sex, which by then we determine whether it's a girl or boy. When girl, they have 2 X chromosome, while men have X and Y chromosomes. Okay, so this is the basic biology behind it. Okay, so this gene, okay, this XX and XY chromosome is the one that causes red-green color blindness in a person, in a human being. Okay, so this gene, the gene that causes red-green color blindness is located on the X chromosome. Okay, not in Y. So only X chromosome. That's why it is known as X-linked, color vision deficiency or X-linked trait. Okay, if let's say you have that gene in your X chromosome, then you will be, you will have high chances to have color vision deficiency. Okay, for male, since there is only one X chromosome, so if let's say the defect is passed to your X chromosome, then you are colorblind. Okay, but for females, okay, they have 2 X chromosome. So if let's say it is only passed to one of the chromosome, then they are carrier for the defect. But if let's say they have on both their chromosomes, then they will have the color vision deficiency carried from their parents. So this is one of the reasons why the prevalence is higher for males, because even if let's say they got in one of their, their sex-linked chromosome in X, they are, considered to be color vision defect person. But for females, they have to get it on both their chromosomes to actually have this color vision deficiency. So consider that women are very lucky because we have 2 X chromosomes. So we no need to actually, it's less prevalent for us. Okay. So this is what it explains. Males have only 1 X chromosome. If their X chromosome has the gene for red-green color blindness, they will have the condition because they don't have another X chromosome to compensate. While for females have 2 X chromosomes, if one of the X chromosome have the gene for red-green color blindness, the other X chromosome without the gene can often compensate. So if let's say another one doesn't have, it will actually help us. Okay, so meaning they usually don't have the condition but can be carriers. They can pass the gene to their children. So this is the reason why if let's say a person is actually having color vision deficiency is usually from the parents, the mother side. Okay, because the mother is the carrier for this, for this disease. So if a mother is a carrier, okay, one of the X is having the defect, but the other one is not, okay, and the father does not have red-green blindness. So each son has 50% of having red-green color blindness. Okay, each daughter has also 50% chance of being the carrier. But if let's say the father has a red-green blindness and the mother does not carry the gene, none of their son will have the condition because they have get their X chromosome from their mother. So all their daughters will be carriers because they get their father's X chromosome with the gene. So this is the reason why I said just now, if let's say, if let's say a son is actually having color vision deficiency, that means they got it from their mother and they got it from their mother's side. Okay, it's not from the father. Okay. Okay, now we're going to compare between hereditary anomalies and acquired anomalies. Okay, hereditary or the inherited one or the congenital one, it is almost always is a red-green defect. Okay, as I explained just now. Okay, XY, chromosomes and all that, they're carried in the sex-linked genes, so it is always red-green. Okay, while this acquired can be red-green or can mostly it is blue-yellow. And the congenital one is more prevalent in males, as I mentioned. The girls will be usually carrier. Okay, so equally prevalent in males and females for acquired. So if let's say it is equal between the gender, the reason why is because anybody can get cataract, anybody can get glaucoma. Okay, and anybody can take any drugs that actually induces this. So there is no partiality in that. And then when it comes to congenital, it is symmetric, same in each eye. Okay, this eye and this eye, they will have the same type of color vision deficiency and the severeness also the same. Okay, but for acquired, it may be asymmetric. Okay, often a difference in severity between the eyes. If let's say only one eye is having, cataract, then only that eye is affected. Okay, so that eye will have a color vision deficient, while the other one could be normal or only have a mild color vision deficiency. And congenital, no history of recent color naming errors. Patient will come into your clinic with the complaint that, okay, I have been having this since, my young days. Okay, while these patients who have acquired anomalies may present with recent history of color naming errors, they would actually come into the clinic with the complaint of, I have recently only people start commenting on, when I actually name a color, they say that, you are saying the wrong thing. Recently only I'm experiencing this. Then it is acquired. Hereditary anomaly stable over time. Okay, stable over time means after, born, maybe after, 1 or 2 years, then it is actually stable. Okay, while acquired anomalies may be unstable, changing over time according to the progression of the ocular condition or the dosage of the drugs that they are taking. And also congenital, easily classified with standard clinical color tests. Okay, with the color vision test like Ishihara plates and all that, once you attempt that, usually you can able to classify the patient without much struggle. While classification often not straightforward with standard clinical color test, and it is non-selective for acquired anomalies depending on the severity of the color vision defect, severity of the ocular condition that they are having, and also the drug concentration, okay, or the dosage. Okay, if let's say higher, then it might be actually worse. Okay, if it is lower, then it might be, lesser. So it distinctively to get a result would be difficult for this patient. And congenital, it is not associated with the disease or toxicity, so it is purely genetic, while acquired associated with ocular or systemic disease or toxicity. Okay, so as I said, ocular condition, their systemic disease, diabetic hypertension, and also the dosage of the drugs that they're using will induce this. Okay, so we have looked at the characteristic of the congenital color vision deficiency, and then we look at the, the prevalence of color vision deficiency, and also we see how it is actually being transferred from the parents to the offspring. And we also looked at the comparison between this inherited one and acquired color vision deficiency, the characteristic that patient would have. Okay, thank you.